adult tachycardia regimen with a pulse algorithm. So whenever you are getting a tachycardia, BTVF, they don't have any pulse, so that is considered to be a cardiac arrest. But when you are getting a adult tachycardia patient or tachycardia patient in adult patient with a pulse, you have to follow this algorithm. Again, in bradycardia, we have assessed the appropriateness of the clinical condition. Here also you have to assess and you have to monitor the heart rate. If the heart rate will be more than 150 per minute, then it is tachyarrhythmia. In bradycardia, we have a heart rate about less than 50. So in this way, when you compare the two algorithms, you can easily remember it. What are the drugs used in tachycardia? What are the drugs used in tachyarrhythmias? What are the drugs used in the bradycardia? What are the drugs used in tachyarrhythmias? So in this way, when you compare both the things, you can easily remember the things. Identify and treat underlying cause. Same thing as bradycardia. Here you have to also maintain the patient airway, oxygen, cardiac monitor, IV access, and 12-lead ECG. Same thing as bradycardia. Now again same thing as bradycardia. If the persistent tachyarrhythmia causing, there we have learned that if the bradycardia causing hypotension, altered mental status, sign of shock, ischemic discomfort, acute heart failure, yes or no. If it is yes, it is no. There also we have learned. Here you are also learning the same thing. If here there if it is no, then you have to monitor again. But no, here the condition changes. So up to this, everything is same in bradycardia and tachycardia. So persistent tachycardia causing hypotension, altered mental status, sign of shock, ischemic cardiac discomfort, or acute heart failure. If it is yes, if it is no. If it is no, see the QRS complex. If there is a white QRS complex for more than 0.12 second, just give it a sinus tachycardia only. Just give some amount of vagal maneuver, adenosine, beta blocker, or consult experts consultations. If the QRS complex is more than 0.12 second, if it is no. If it is yes, consider adenosine only if regular and monomorphic, antiarrhythmic infusions, and consult expert consultations. If the QRS complex is wide or narrow, if it is the narrow QRS complex, mostly it will be a sinus rhythm. So vagal maneuver, simple vagal maneuver is enough for the patient. Otherwise, go for a small amount of adenosine, beta blocker, calcium channel blocker. What the drugs which decrease the heart rate, go and giving this type of drug. If there will be wide QRS complex, then there are chances of changes and there are chances of arrhythmia. Here we will give adenosine only if the patient is having regular and monomorphic type of arrhythmia. Antiarrhythmic infusions like adenosine, like amiodarone or lidocaine, and expert consultations. If the tachycardia causing life activities or life danger activities or very much danger to the health, like hypotension, altered mental status, sign of shock, ischemic discomfort, acute heart failure, here we will go simply for cardioversion. Synchronized cardioversion, sedation the patient, because this cardioversion will cause some amount of pain. So consider for sedation. If regular narrow complex, consider adenosine. PSBT, that means. So yeah, ECG will discuss completely, but here only for the sake of completions of the algorithm I am keeping tachycardia. So synchronized cardioversion we have to give in if the patient is having a sign of shock, mental status, or sign of life danger. If the tachycardia causing some amount of symptoms like that, hypotension, altered mental status, sign of shock, then you have to give a synchronized cardioversion. If refractory, if after giving cardioversion also, after giving drug also, the tachycardia is not resolving and the tachycardia is persisting in the patient, you have to treat the underlying cause. You have to increase the energy to the level of next cardioversion, addition of antiarrhythmic drugs, and also expert consultations. Expert consultation everywhere. Here is expert consultation, expert consultation. Okay. So what is the dose? Synchronized cardioversion. Synchronized cardioversion, you have to refer the device recommendation energy level to maximize first shock and second shock. So in case of also that VTVF, we are providing a shock monomorphic and biphasic 120 to 200. So there is no any such recommendation for synchronized cardioversion. Refer to your specific device recommended energy level to maximize first shock success. Adenosine IV access, what is the dose? The dose is 6 mg repeat IV push followed by NH plus whatever, because adenosine is very much short acting. It is metabolized by plasma esterase. So therefore, we give 6 mg IV push followed by NH plus, so that the 6 mg can easily go to the heart. The second dose is always higher than the first dose, that is 12 mg if required. Mostly the single dose is suffice, but if the tachycardia is persisting or the PSVT is persisting, we provide 12 milligram additional. Antiarrhythmic infusion for stable wide QRS tachycardia like procainamide IV dose, that is 20 to 50 milligram per minute. What are the drugs you see? Yeah, they are in case of bradycardia, that is the dopamine, atropine and epinephrine. Here in case of tachycardia, procainamide, maintenance infusion and amiodarone. So see, procainamide 20 to 50 milligram per minute until arrhythmia suspended, hypotension ensues, QRS duration increase by more than 50%, and maximum dose is the 17 milligram per kg. So procainamide maximum dose is 17 milligram per kg. Maintenance infusion 1 to 4 milligram per minute. Avoid if prolonged QT or chronic heart failure. If the patient is having prolonged QT or congestive cardiac failure, you have to avoid this drug. Coming to the second drug, that is amiodarone. First drug is 150 milligram over 10 minutes. Repeat as if the VT reoccurs. Follow by the maintenance infusion of 1 milligram for first 6 hours and again 0.5 milligram minute for again 12 hours. So this is the dose of the amiodarone. Sotalol. IV dose is 100 milligram, 1.5 milligram per kg over 5 minutes. Avoid if the prolonged QT. So there are 3 drugs again here: procainamide, amiodarone and sotalol. There are also 3 drugs: atropine, epinephrine and dopamine. 3 drugs. Okay, but for synchronized cardioversion or PSVT, like what is the drug of the choice for PSVT? It is adenosine. What is the drug? Initial 6 milligram, another is 12 milligram. So in this way we learn about the adult tachycardia regimen. So in case of tachycardia, you have to see the QRS complex, whether it is narrow QRS complex or wide QRS complex. If you have to narrow QRS complex, the treatment is different. If it is wide QRS complex, the treatment is different. Wide QRS complex, anything can be happen. VT, VF, anything can be happen. Okay, but in case of narrow QRS complex, this PSVT, sinus tachycardia, this type of things comes in case of narrow tachycardia, narrow QRS complex regimen. So the drug mostly used for 2 antiarrhythmic drugs like procainamide, amiodarone and sotalol. And if the patient is having PSVT, like they think the adenosine is the drug of choice. So this is adult tachycardia regimen.